I'm Joachim Rigotti and we're going to talk about fibromyalgia with a particular emphasis on the management of it. Now, in my previous little presentation, we looked at the theory and the physiology behind fibromyalgia, so I'd highly recommend you watch that video as well. But just to recap that video, we're going to quickly go through actually what is fibromyalgia before moving into the management. So let's recap. The first thing is, what even is fibromyalgia? The main symptom of fibromyalgia is chronic widespread pain. That is the first symptom we should really think of. It is pain throughout the body. So it's not a specific pain such as a whiplash or a chronic low back pain. We have pain in every area of the body. There may also be other symptoms. We may have some fatigue, sleep disturbances, some memory issues, as well as other conditions which are often associated. IBS, headaches, and also some psychiatric stuff such as anxiety or depression. So there are a few additional symptoms, but the main one we think of is the widespread pain. It is actually also quite a common condition. Around 2 to 5% of the population are sufferers, which puts it in line with around chronic low back pain and depression. So it's a big condition. It's not a rare one. We then talked through a few things we need to adjust our mindset away from the classic disease-based model of medicine. And the first thing was really talking about pain. When we think of pain, we have to think of it as an experience rather than a sensation. We tend to think pain is purely the representation of the amount of damage in our tissues. So if there's more damage, we have more pain. However, there is no single pain center within the brain. Rather, there are multiple areas throughout the brain which all synchronously activate, and that gives us the experience of pain. So if any one of those areas increases in activity, then we have an increase in pain. And we can separate it into two broad categories. Those areas which do deal with the actual physical sensations from damage to our tissues, muscles, tendons, ligaments, and joints, and those areas which really deal with what we focus on, including the emotional and situational context. We could call them the psychological component. And the combination of the physical sensation and the psychological component give us the pain experience. So we may have either an increase in physical injury or an increase in emotional distress, and either one of those will give us an increase in the pain experience. Next little point. Fibromyalgia is a syndrome, not a disease. Now, we always tend to think of diseases first when we talk about medical conditions, and diseases follow the perfect story. They tend to have a single, well-documented cause. You may eat a bacteria within a food, bitten by a snake. There are just a very clear cause, and then it has a very nice physiology that we can follow. However, a syndrome is the reverse. Rather than beginning with the triggering event, a syndrome is diagnosed with the symptoms first. So we start at the end. An individual is presenting with symptoms, and if two individuals have the same symptoms, no matter what has caused it, they kind of get given the same diagnosis because they have similar symptoms. So in fibromyalgia, we tend to look for the pain, and then the fatigue, sleep, memory issues, and the depression, headaches, and IBS symptoms. And if individuals tend to coalesce around those symptoms, then they are given the same diagnosis. However, it does not mean they have the same cause or that they'll have the same pathway to get there. So whilst individuals may present the same, because fibromyalgia is a syndrome, they may well have very different causes. And that leads us to the next point, that there is no single cause to fibromyalgia. We tend to always think, what is the cause? And actually with a syndrome like fibromyalgia, there may be multiple different types of fibromyalgia, and indeed therefore there may be multiple different types of causes. And that of course links into management, what we'll talk about today. Because there might be multiple different causes, we do not currently have a cure for fibromyalgia. In order to have a cure, you really need to have a very specific thing you can focus on and then work over time to try and target it. But in the case of fibromyalgia, because it could be multiple things, we yet don't have a cure. And the last point is really about the pain from fibromyalgia. The pain is coming from the central nervous system. And this links back to about pain experience. Where does the pain come from? And in fibromyalgia, what seems to occur is that actually most of the pain is coming from the central nervous system rather than the periphery. So it's not related to the amount of tissue damage. It's all about the actual pain pathway generating and amplifying signals. We're going to then quickly touch on the pathophysiology. So what actually happens in fibromyalgia? The first thing, we have our risk factors. So the risk factors for fibromyalgia all coalesce around stress, psychological and physiological. If we've had an infection, a trauma, a rheumatological condition like rheumatoid arthritis, that all predisposes to fibromyalgia. Similar with psychological stress. If we have childhood trauma, the early life adversities, and any of these psychiatric conditions, anxiety, depression, all of those put us at an increased risk for fibromyalgia. And because females are more likely to have those individual risk factors, they are predisposed to fibromyalgia around 1.5 to 2 times as much compared to males. Now, once we have those risk factors, usually there is then a triggering event. Something sparks off the fibromyalgia. And what seems to happen is for some reason we are affected by something which triggers our pain pathway. So something is triggering our pain pathway again and again and again. And it is this area where there's a lot of controversy. What exactly is it that triggers fibromyalgia? And again, to reiterate, because it's a syndrome, there is no one thing. Different people may have had different triggers for their fibromyalgia. It may have been a rheumatological condition, it may have been a neurological or an endocrine or a connective tissue issue, or a toxin, a medication, an infection. There could be multiple different causes that trigger the pain pathway to be activated. And then once that pain pathway is activated again and again and again, it adapts to pain. And it is therefore those end adaptations which then maintain the chronic pain, and then we finally have fibromyalgia. And that's where I said before that fibromyalgia really occurs because of the changes to the nervous system. That last part, the end changes. We're now going to move on to the clinical pathway. So we'll quickly touch on what should be step-by-step be of an individual with a suspected fibromyalgia. The first place to start is the diagnosis. Is this a case of fibromyalgia? And we include the widespread pain index and the symptom severity score. So we're looking for, is there widespread pain across the body? And do they have any other symptoms which tend to be seen in fibromyalgia? The fatigue, sleep disturbances, and the memory issues. And we also want to see, are there any of the other associated conditions, the IBS or stomach issues, any headaches, so tension type and migraine headaches, and is there any low mood conditions which are kind of representative of depression. So once we have that, we then also need to just make sure, are there any other possible diagnoses? Is it rheumatological, neurological, endocrinological? Is there an infection, a connective tissue disorder? Just to rule out, could this pain throughout the body actually be from another medical condition? We just want to rule that out. Along with checking if there are any other diagnoses, we then want to do some tests. Now, there is no single fibromyalgia test. Rather, what we're trying to do with tests is just to see, are there any general health issues which may be contributing to the picture that we may need to resolve. So we want a complete blood panel, metabolic panel. We want to look, is there anemia, low vitamin D? We may want to check for any autoimmune things, a rheumatological factor, and an ANA test, just if there is suspected rheumatological conditions. And all of that is really just to see, are there any underlying health issues that we need to correct first? Once we have all that data, we have done the diagnosis, we've seen is there any other things that it could be, we've done the tests, then we can categorize them. Is this an individual for sure with fibromyalgia, where they meet the criteria and there is no other possible diagnosis? The other possibility would be a comorbid fibromyalgia. Yes, they do have another underlying condition. However, that underlying condition does not explain all the symptoms. So they may have rheumatological conditions, they may have rheumatoid arthritis, but that does not explain all the clinical pictures. So they may have both a comorbid fibromyalgia. And the final category would be no fibromyalgia. Either they don't meet the diagnostic criteria, or that there is another diagnosis that explains all their symptoms. If there is an underlying condition, they of course need to go and see a specialist. If it is a rheumatological condition, they need to see a rheumatologist. If it's a neurological condition, they need to see a neurologist. So the specialists need to be seen if there is an underlying condition present. And then the final step would be the management. Once we've categorized them, okay, this is an individual with fibromyalgia, we then move on to the management, which is what this talk is all about. And the final step would be, if the management fails, then we refer to a specialist. All right, here we are, the place we really want to get to, the management. How do we best manage individuals with fibromyalgia? And the first question to ask is cure versus care. So do we need to focus on removing the pain or help people cope and live with it? And the real answer is that there is no cure for fibromyalgia, therefore we must focus on care. Now, usually with a disease, there is a cure, so we need to focus on that. Yes, we want to make the person comfortable, but if you can completely remove the condition, then that's where we should really be aiming. But because fibromyalgia has no cure, our whole emphasis is on care. And we'll quickly go through the difference between them. So with a cure, we're always sort of looking to eliminate the root cause. We might have an anti-venom, we may have an antibiotic. There is some medication which goes to the root cause and eliminates it. However, when we're looking at caring, we really are just trying to help control the symptoms and improve the quality of life. So it's really looking at how does that individual feel rather than using some metrics to see how is the condition doing. So it's all about how the person feels. And that leads into the next part about curing. We tend to use an objective measurement. For example, with diabetes, if we wanted to try and cure somebody's diabetes, we would be monitoring their blood glucose or their hemoglobin A1C, for example, and those are objective measurements. How is their condition doing? However, with a care, particularly with fibromyalgia, we don't really have any objective measurements to go off. So it's all about how the person feels. And this is quite an important part when it comes to things such as medications, where if the person feels it's not improving, that's all that matters. Their subjective opinion really matters because that's all we can help improve. So if they feel it's not helping, then we need to discontinue it. We're always looking at how does that person feel the treatment is going, because that's all we can do. So if it doesn't feel like it's helping them, then why are we doing it? Compared to if it's a cure, even if the person doesn't like some side effects, perhaps if we know this is going to cure them, we can balance out a little bit more. But with a care, when we're caring for somebody, it's all about how they feel. And then we'll fly through these next bits. So the cure, there tends to be a permanent resolution. We've cured it, it's all gone, it has been resolved. But when we're caring for something, we have to expect that the condition will persist. So it's an ongoing care. And the last part is all about sort of the managements that tend to be used. When we're curing something, because it tends to be something very specific, we also use a very specific treatment. So we can really target what we're looking at. And you see that with most cures, they target a very specific area. However, when we're looking to care for somebody, we really don't have that specific thing we're targeting. So we use a broader approach and use multiple disciplines in order to help that individual. The next question is specific versus general. So do we need targeted therapies in fibromyalgia or a broad approach? And the answer, we already kind of touched on it, is that fibromyalgia, because it occurs from multiple changes to the pain pathway, it doesn't come from a specific change, therefore we need a broad approach to management. And when we look at the management, the area we're focusing on are those end changes. Now, a specialist may be able to target the triggers. So if we are suspicious that perhaps it's an autoimmune condition, for example, that has triggered it, then we may be able to focus on the triggers. However, for most individuals with fibromyalgia, our target are those end changes. We're trying to reverse those chronic pain adaptations, trying to reverse it so we can help reduce the symptoms of pain. And here is the management pathway. So where do we begin and how do we progress if certain things fail? What's stage 1, 2, 3, for example? The first place we always would start with education and advice, really helping the person to understand their condition and giving them some broad advice of what to expect. From there, we then start with some physical activity and rehabilitation, some things which are very gentle just to get us moving. So that is really the first intervention we give. Now, if that doesn't suffice, or we feel that we need to add something in, then we will add a psychological therapy. So an acceptance commitment based therapy or a cognitive behavioral therapy on top of the physical activity. Now, if both of those seem to not really scratch the surface, we don't see any improvements, that is when we add pharmacology. We start to add medications. We don't start with medications, we first trial some non-invasive techniques such as physical activity and psychological therapies, and if those don't seem to work, then we add pharmacology. And finally, if nothing seems to be working, then perhaps again we need to refer to a specialist. Now let's go through each one of these in a little bit more detail. So the first place we would start is with education and advice. So we have an individual who has a fibromyalgia diagnosis. What do we do with them? Well, the first thing is give them a diagnosis. It may be controversial to label a condition, but actually sometimes it can be really helpful, especially with somebody who perhaps has gone through the medical system multiple times and is very unsure as to what's going on. Being able to ground an individual with a label and a condition really helps to focus them and can actually help reduce some anxiety. Okay, we think we know what may be going on, and therefore we think we may have some roots which may help, rather than the opposite approach of saying we have no idea what's going on and therefore we have no idea what might help. Rather, giving a diagnosis really helps to focus us on what we may be able to do for that individual. From there, we also really need to be validating concerns. Individuals with fibromyalgia, due to the nature of the condition, quite often have a lot of bad press thrown at them. They may meet medical professionals which do not believe in the condition. They may have a lot of social pressure placed on them that they are making it up. So really validating that fibromyalgia is indeed a proper condition, if I'm allowed to use that word, rather than something that's just in their head. It is actually a real physiological change, can really help validate that person's concerns, that what they have felt in the past and are currently feeling is a genuine thing. So really trying to validate that fibromyalgia is a true diagnosis. From there, it's just about understanding the physiology. What actually is fibromyalgia? And one of the key differences to really understand is the difference between a central versus a peripheral pain. So peripheral pain is pain that's really generated from tissue damage. Think of osteoarthritis or an actual acute injury. You slam your finger in the door. That's injury to the tissues, and that's where the pain is coming from. That's peripheral. However, with fibromyalgia, the pain is not really coming from the periphery, our tissues. It's really coming from the central nervous system, our spinal cord and our brain. So that's why the treatment is slightly different to if we had an inflammatory condition or a tissue injury. So that's a really important thing to distinguish between peripheral pain and central pain. Next, all about pain fluctuations and pain flare-ups. Pain can wax and wane due to, as we explained before, pain being an experience. It is not a pure representation of the amount of tissue damage. Many things contribute to the pain experience, and therefore any increase in our physical or psychological stress will boost our pain experience. So we have to expect pain flare-ups, as we kind of have to expect that at some point our body will be placed under additional stress, and that may well then be followed by an increase in pain. So we have to expect a pain flare-up. It's just something we have to accept. what we have to try and avoid in those pain flare-ups is really battering ourselves mentally, really pushing ourselves down psychologically, and understand that they tend to be a temporary increase and they are not correlated with the amount of tissue damage. The next thing we may want to know is the link between pain pathways and psychological circuits, going into again that multiple brain areas are used. And this is why if the brain circuit which is involved in pain is overused, it just so happens that that very same circuit overlaps with brain circuits involved in anxiety and major depressive disorder. And therefore we may get secondary psychological effects such as anxiety or low mood due to the same circuits being used in generating pain. So there's a big correlation between the pain experience and psychological. And this also links to some people may describe fibromyalgia as a psychiatric disorder, which it is not. Now, fibromyalgia may lead to some psychiatric disorders, the anxieties and the low mood disorders. However, it does not start with those. It starts with the chronic pain, and the overuse of the brain circuits that are used in the pain experience then leads to the psychiatric issues. It's not the other way around. So that's an important aspect. The final thing to know is actually about the management itself. That currently there is no cure or a single pharmaceutical which alleviates all symptoms. We are always just working on what little things can we improve and where. And actually there may be room for hope. Because fibromyalgia is such a widespread disorder, it does give us many little opportunities to make a difference. So we may see lots of different symptoms, and therefore there may be lots of small opportunities to make a slight difference. However, there is currently no complete cure which will remove all symptoms. So that's the first part, education and advice. Now, along with that, we perhaps may give advice on diet. Now, fibromyalgia is not an inflammatory condition. However, improving inflammation may help us in reducing some symptoms, as inflammation tends to be a little bit of an input into the pain pathway. So anything we can do to reduce how much input there is to the pain pathway will be beneficial. And that is why the mechanism of action for diet tends to revolve around reducing inflammation, as well as improving any metabolic issues. And it may also impact any autoimmunity. So a restrictive diet, perhaps we are consuming some foods which are just triggering our immune system slightly. That little trigger just boosts how active our immune system is. Therefore, we have a slight little increase in inflammation, and that inflammation may serve as an input to the pain pathway. So if we can reduce that, hopefully we may have a beneficial impact on the pain. Now, what diets tend to be recommended? Well, the ones which have been studied the most are the Mediterranean diet and something called the FODMAP diet. And the FODMAP diet is a restrictive diet, and it's restricting foods which may not be easily digested. So it stands for a diet low in fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And you can look online for that sort of diet, and it tends to be mainly foods which people may not be able to digest very easily, and so those foods begin to ferment, they create gas, and it is that increasing gas which may give some stomach issues, some discomfort. So those are the two diets, Mediterranean and the FODMAP diet. There also may be some supplements, and the supplements which have been studied and therefore may be recommended are vitamin D, magnesium, and omega-3. Now, they're not very specific supplements. They have really broad ranging activities. However, they have shown some improvement in individuals with chronic pain. Along with the advice for diet, we may also do some advice for sleep. If we have poor sleep, that is just going to make us more sensitive to everything, including pain. Now, of course, there may be a bit of a catch-22 where fibromyalgia impacts sleep and sleep impacts fibromyalgia. So it can be a hard cycle to break, and therefore we may have to be doing other things first before we can really tackle sleep. But we can always start with just some general advice. So with most sleep, we really try and reduce any stresses and underlying conditions which may be contributing. And as I said just then, trying to just remove fibromyalgia first before tackling sleep isn't really possible. So we're just really looking for, are there any work or life stresses that we might be able to shift whilst we're focusing on sleep? From there, we look at sleep hygiene, making sure that we're reducing our blue light exposure, our caffeine use, trying to reduce our core temperature before we go to bed, trying to condition ourselves that our bedroom and our bed are only for sleeping rather than for sleep and work and breakfast, trying to really make sure that we are conditioned so that when we go to bed, our body knows it's time to sleep. If that fails, we can move on to a cognitive behavioral therapy for insomnia, so CBTI for short. And one thing that CBTI adds in along with the sleep hygiene is something called sleep restriction. And the way this works is we calculate roughly how long we actually tend to sleep for. So for example, we may go to bed at 10 o'clock, but we may then spend 5 hours awake, only to then sleep for 4 hours. So whilst we're in bed for 8 hours, we actually only sleep for 4 hours. And the way CBTI would work is it would then say, okay, if we are only sleeping for 4 hours, that is how long we need to be in bed for. So rather than just staying in bed awake for hours and hours, we're going to restrict how long we're in bed to match in general how long we tend to sleep for. And that is really trying to condition us so that when we're in bed, we fall asleep. So that's really the underlying principle of CBTI. We may also do a melatonin supplement. So melatonin is the sleep hormone. It kind of tells our whole body it's nighttime, it's time to revert into sleep. So perhaps a melatonin supplement may be of use. And the final thing, and this really tends to be a last ditch solution, is hypnotics, so medications which make us drowsy. And these are not for long-term use, and really you have to have tried a lot of other things before you can get a prescription for hypnotics. But for insomnia, they can be recommended right at the end of treatment. And we move on to now physical activity. So those were the advice, all the advice on understanding fibromyalgia, on diet, and on sleep. And now we get on to physical activity. And physical activity is a really broad impact on the body. It really impacts everything, all the way from the muscles to the nerves to the spinal cord to the brainstem to the brain. It really impacts everything. So when we look at trying to impact pain, these broad approaches are really what we're after, which is why physical activity tends to be recommended so much. In terms of what type of physical activity, it's cardiovascular exercise, so that can be your walking, your cycling, your swimming, and then also strength training, so that can be body weight exercises, or it can be resistance training in the gym, something where we're pushing a little more rather than an ongoing exercise. Now, stretching doesn't tend to be recommended immediately, and that's more of a physical rehabilitation issue, where if you stretch first, you actually run the risk of removing tight muscles which were providing stability. So you might actually end up increasing the amount of instability because you've removed tight muscles which were actually playing a role in keeping a joint stable. So we always strengthen first before we stretch. So that's why when we first begin, cardiovascular and strength training is what we do. And the evidence tends to point to a more low intensity rather than high intensity. And you probably will be forced in that direction anyway, as high intensity exercise tends to come with a lot of pain. It tends to really damage the muscles, and any increase in pain is really something we want to avoid. So we start slow and really progress very slowly. And in terms of how hard we actually push, the research tends to suggest that for cardiovascular exercise, our walking, swimming, cycling, all those sort of things, we're looking for about a 5 or 6 out of 10. So we should still be able to hold a conversation, but we should be noticeably out of breath. So we are working, but we're not really pushing ourselves hard. So 5 or 6 out of 10. Now, if we were to looking at strength training, resistance training, we're looking for around 40% of our maximal strength. So quite low. And again, that's really because we don't want to damage our muscles excessively and give us more pain. This is a long-term project, not a short-term fix. And along with trying to keep the weights quite low, we actually want to start with isometric exercises. So those are the exercises where we're not actually moving. So we're contracting the muscle and then relaxing. And that tends to sort of have the least amount of muscle damage compared to concentric exercise and even more eccentric exercise. So we start with isometrics. And as always, when we first begin, we really want to start below our physical capacity. We don't want to really test ourselves from day one. We want to build a bit of confidence, really feel like, oh no, this is something I can do. So there's no harm in starting with a really low amount of resistance or quite an easy exercise, just to begin to build a bit of confidence. And that's physical activity. Next, we move on to physical therapy. So these are really the hands-on modalities. And really the emphasis on these is to improve the biomechanics. How does the body work? That's our posture, how our joints move. All those things are what we're focusing on in order to reduce how much they may be contributing to the pain. And those will include rehabilitation exercises that will bolt on to our physical activity. They may include massage therapy, but with massage therapy, we want to avoid excess pressure. We're not there to feel the burn or feel any pain. We're just there to really get a nice little signal into the muscles. We may also do acupuncture or dry needling. And those are the physical therapies which tend to be most researched in fibromyalgia. Next, cognitive therapies. So these are all the psychological work. And the way they are working is because pain is that experience, it is the combination of physical sensations and our psychological mindset, they are targeting that aspect. So the brain circuits involved in the emotional and situational context is what we are aiming for. And the type of therapies that have been most studied are the cognitive behavioral therapies, which are targeting anxiety. The reason we want to target sort of an anxiety-based therapy is because of those overlapping circuits. The circuits which deal with pain overlap with those which generate anxiety. So if we have a program which focuses on anxiety, we are actually targeting the same brain areas which are involved in helping to generate pain. So whilst we are performing an anxiety program, we may not actually be doing it because the individual has anxiety. We are doing it because we are trying to target the very same brain areas. The only issue with cognitive therapies tends to be the adherence and the compliance, because it takes a lot of homework and self-reflection, and it's actually quite hard work to do. Occasionally the adherence may not be what we wish. So we really want to try and stay on top of that. Now we move on to kind of the final possibility. So if we have done the physical activity, we have done the psychological work, and we still don't have a satisfactory improvement, then we can move on to pharmacology. And really, the main pharmacology that is recommended throughout the board in multiple countries is antidepressants. And when we talk about antidepressants, we tend to have an issue with the word antidepressants. That therefore, if it's an antidepressant, it must only be for depression. However, at the end of the day, these are actually serotonin and norepinephrine reuptake inhibitors. And what they are doing are boosting how much serotonin and norepinephrine we have in our nervous system. Now that happens to perhaps have a benefit on major depressive disorder, but actually they may have other things which are beneficial. And in the case of fibromyalgia, what it does is it increases norepinephrine in the spinal cord. And norepinephrine is the very chemical behind the placebo effect, as well as perhaps any pain reduction we have when we're physically active. When norepinephrine is released in the spinal cord, it dampens our pain. And therefore, the theory is if we take an antidepressant which helps boost norepinephrine, the most commonly used are duloxetine or a tricyclic antidepressant such as amitriptyline. When we take those, they help boost norepinephrine, which will help dampen the pain. And they do tend to be started at a lower dose than we would take for a depression. The other class of medications are those for neuropathic pain. So these are the gabapentinoids. Gabapentin, pregabalin. Pregabalin would tend to be the one most commonly used. It's the newer one. It has the same mechanism of action, but it's just a lot easier to take for the individual. Now, the only issue here is that it is recommended in things such as in America, and you may see it in rheumatology books. However, the NICE guidelines in the UK do not recommend these medications, mainly because of the side effects they can have. So you may hear about individuals being put on it. However, it is not actually recommended as a first line. It really is given from a specialist when their other treatments have not worked. So neuropathic pain medications such as gabapentin and pregabalin may be given. The next is low-dose naltrexone. Now, naltrexone is an opioid antagonist. So if somebody has had an opioid overdose, they are given naltrexone. However, in low doses, naltrexone actually seems to have almost a reverse effect. What it does is it increases how sensitive our spinal cord is to opioids. And opioids are pain-reducing agents. And our body produces opioids naturally. However, it's possible that in fibromyalgia, our body is producing so much opioids that we almost start to become desensitized to it. So giving a low dose of naltrexone increases our body's sensitivity to opioids, and we may be able to get a little bit of an effect there. They might also impact the immune cells around the spinal cord, the microglial cells, reducing how active they are, and that will have a beneficial impact on our pain symptoms. That also leads into perhaps another class of drugs, immunosuppressants. And you will see this in a research-based. When there is a suspected autoimmune cause to fibromyalgia, because it's an autoimmune condition, they may well try different immunosuppressants. One which seems to repeatedly come up is minocycline, which will reduce the activity of the immune cells in the spinal cord, particularly the microglial cells, and that might well have a beneficial impact on fibromyalgia. And really the finishing thing to say about pharmacology is that actually only 30 to 40% of people on pharmacology for fibromyalgia have a beneficial or a satisfactory outcome. So they are by no means a cure, but they are a last line of defense, so it's always worth trying if other things have failed. The last thing to touch on is to see a specialist. And we really see a specialist in two situations. The first one is right at the start of the diagnosis process. If there seems to be an underlying pathology which requires a specialist, then they need to go and see that specialist. The other one is if all those managements seem to have failed, we've given advice, we've then did physical activity, we've done the psychological therapies, we then tried antidepressants, but they have all failed, then it is warranted to go and see a specialist. Now the question is, who would you go and see? There currently isn't a fibromyalgia specialist. However, if you read the research or you read books, what tends to be the pattern is that nowadays it has moved over to the world of rheumatology. So it appears that the world of rheumatology, so rheumatologists, tend to be those who are exposed to the most information on fibromyalgia. So perhaps the best specialist to see would be a rheumatologist. Now let's quickly conclude. If you have fibromyalgia or we're working with someone who does, what is the program of management? We begin with education and advice, understanding what is fibromyalgia, understanding that pain flare-ups happen, that pain is an experience. So an increase in physical stress or psychological stress will increase pain, but it tends to be temporary. And we also need to understand that it seems to be an ongoing process, so we may not be able to cure it, but we will do everything we can to try and manage symptoms. From the advice and education, we then move to a physical activity program, cardiovascular and strength training, really starting low and going slow. From there, we would move on to psychological therapies, cognitive behavioral therapies, with a particular emphasis on programs which work on anxiety pathways, because those overlap with the same pathways involved in generating pain. If those two management techniques have not worked, then we move to pharmacology, mainly looking at antidepressants, those that increase norepinephrine. So duloxetine and amitriptyline tend to be the most common. And if that fails, then we go and see a specialist, and currently the probable best person to see would be a rheumatologist. And that concludes this presentation. Thank you for watching this video on the management of fibromyalgia. If you did enjoy this video or found it helpful, then please do leave it a like. And if you think there is somebody else who may benefit from this video, then do share it with them. Furthermore, if you would like to see more of these videos in the future, please do stay subscribed. And if you have any comments on the video itself or any future topics that I might be able to cover, then do leave me a comment. Thank you.